You are most welcome to today's video. Thank you for coming back. Always appreciate it. Now, today's video is not for everyone, but I'm going to give a bottom line on it first. I've been looking at four scientific studies that have been recently published. But it's not just any four studies. It's studies that I believe are going to have a great significant impact on what happens to us all over the next few months. And the first one, this is just to give you the bottom line briefly, the first one relates to the Russian vaccine. Now, this has actually been published in The Lancet, which I thought was a reputable medical journal. But it turns out that The Lancet have published this paper about the Russian phase 1 and phase 2 clinical trials. And the number of subjects that they're reporting on is 76. This is not a big number for vaccine trials. 76. And it sounds like on the basis of these 76 cases published in The Lancet, at last, they're going to be starting phase 3 clinical trials in Mexico. So that's a bit of a concern, but we'll look at the detail. The good news is it does seem that the virus, an immune response to the virus is generated by the Russian vaccine. But to get a paper published in The Lancet with 76 subjects, yeah, more of that later. Now, the next paper is going to look at children as asymptomatic spreaders. Looks like about 42% of children are going to have no symptoms but spread the virus. Some will develop symptoms later, but it looks like they're spreading the virus a lot. Now, the reason I wanted to do this one was, of course, children are going back to school all over the United States, all over Europe. And I think that they're going to be a massive epicenter of new contagion. This is my current understanding of the situation. So I wanted to talk about that. And this paper is showing that children can shed viruses for longer than we'd thought. Now, the third paper is on viral load and mortality, and it's very simple. When people are admitted to hospital, the higher their viral load, the more likely they are to get very sick, the more likely they are to die. And this is so important because we've looked at this idea that the viral load someone is infected with is going to determine how sick they are going to get. Meaning that simple things like hand washing and wearing a mask can protect me as the non-infected mask wearer, because I will get a lower infecting dose of the virus, therefore more likely to get an asymptomatic or minimally symptomatic course of disease, but a course of disease which should still engender immunity. So interesting science coming out there, and I think you can see the import of this for the pandemic panning out over the next few months. And the final one is on steroids. Now, on top of your kidneys on either side, you've got a gland called the adrenal gland. It's got an inside bit called the medulla. It's got an outside bit called the cortex. And this outside bit called the cortex secretes what we call steroid hormones, hydrocortisone, corticosteroid type hormones. And this is where we get the word steroid drugs from. Now, steroid drugs are massively inflammatory. And the evidence that these are efficacious in certain cases of people with COVID-19 is accumulating. It's got the potential to save many, many lives around the world. So we'll be looking at that as well. So the science we're going to talk about has massive import on the way this pandemic unfolds. So do stay with us. There's nothing too complicated. So I would encourage you to stay. But if you want to leave now, I understand. And hopefully we'll see you again soon. But for those that are staying, I'm staying. Hey, keep me company. Right, the Russian vaccine. Now, this is published in The Lancet. Now, when I started reporting on these COVID-19 videos, way back in January, been doing this for some time now. This is way back in January, when I worked out there was going to be a pandemic in January, when the World Health Organization was still pretty well saying otherwise. And I remember reporting from The Lancet and saying this is one of the most reputable medical journals in the world, and at that time I thought it was. But there are question marks coming about it now, and this is really quite disturbing, really. I mean, basically, I think we can still trust it, but there's question marks, and there just shouldn't be any question marks about this caliber of journal. There just shouldn't be. Anyway, I'm not getting into conspiracy theories. I'm going to back this up with fact, and you'll just have to judge for yourself. This Lancet paper, it appears to be peer-reviewed. 2 early phase trials, so phase 1 and phase 2, giving 2 doses of the vaccine, and they report on 76 patients. Now, they're actually giving 2 forms of the vaccine, so the actual number that got each form of the vaccine was only half of that. So the numbers here are remarkably small. Remarkably small. As well as that, it was open label. That means the patients knew what they were getting. There was no placebo control. It was not randomised in any way, shape or form, as we would expect with a good clinical trial. And it was all healthy adult volunteers between the ages of 18 and 60, as we would expect in a phase 1 or a phase 2 trial. But of course, it means we don't know how it's going to affect children, old people, people with comorbidities. We simply don't know that yet. This information is a mystery to humanity at the moment. So clearly we need phase 3 trials. That needs to be randomised. They need to be blinded. Blinded means that the people who get the vaccine don't know whether they're getting the vaccine or whether they're getting a placebo. It has to be blinded, so it needs to be randomised. So who gets the placebo and who gets the active vaccine is on purely random allocation. Otherwise, we get the possibility of human subjectivity coming in that can completely mess up the results. So it's got to be randomised, so far it's not. It's got to be blinded, so far it's not. It's got to be placebo controlled. So we've got a group to compare it with. So far it is not. So that's what we need, and it's not where we are at. Now, they tried out 2 formulations of this, frozen and lyophilised. Now, lyophilised means, basically means freeze-dried. The product is frozen at the same time that it's dehydrated. Now, I must say I've never used vaccines of this type, but it would mean that they would need to be transported around the world frozen. Vaccines I've used in the past, often in remote situations, we've had to maintain a vigorous cold chain where we wanted to maintain the vaccine at about 4 or 5 degrees centigrade ideally. I once did a vaccination campaign in a refugee situation and the temperature outside was about 35 degrees. So keeping the vaccine cool was a major challenge without electricity. And basically you have to put it straight from the fridge in the morning into cool boxes, so the cold chain's a well recognised problem. So transporting these around the world frozen would actually probably be easier than at 5 degrees centigrade. So that's not a problem, but it shows they've got 2 formulations, so they haven't quite worked out which is best yet. It is what it's showing. But the vaccine cold chain is a well recognised need all around the world whenever vaccination programmes are being performed. Now, both of these preparations, whether it was straight frozen or freeze-dried frozen, 21 days after everyone developed antibodies apparently, or 76, so the paper says. 28 days all developed a T-cell response. Now, if this is accurate, and we've no reason to assume that this is not accurate, this is excellent. Based on a small sample size, 100% are developing antibodies, immunoglobulin type Gs, and 28 days everyone's developing a T-cell response. Remember, it's the T-cell response we expect to be longer lived, especially these cytotoxic T-cells that would directly kill virally infected cells. And once there's a good T-cell response, my personal view is, it's not proved by evidence yet, but my personal view is the immunity could last for years. So that's what they are claiming, albeit based on this small sample size. And at 42 days, they're saying it has a good safety profile. Let's hope that's right. Specifically, what they're saying is, with the Russian vaccine, mild local and systemic side effects. And we looked at this a couple of days ago with the American vaccines. Again, it's exactly what we would expect. Nothing alarming there, nothing out of the ordinary. It's what we would expect. No serious adverse events were detected. Good. But remember, this was on a small sample size. They were all previously healthy. But they report no adverse effects. 2-part vaccine. Now, it's a bit complicated. It's 2-part vaccine. It's 2 attenuated recombinated adenovirus vectors. Now, right, let's explain that. So what they've done is they've got 2 recombinant adenoviruses. Now, recombinant means what they've done. as far as I can read this paper, is they've taken some of the RNA from the coronavirus, from the SARS coronavirus 2, and they've implanted this as a gene into these adenoviruses. Now, the adenoviruses are common. We've all had them as children. They can cause infections in the mouth, the throat, the respiratory tract, the GI tract. They're very common viruses. Most adults don't get frank viral disease with adenoviruses because we had them as children. So basically, this seems to have genetically modified these two adenoviruses. So that part of the adenovirus, that's sticking out of the adenovirus like that, we would assume, that pen top there, imagine my hands are the adenovirus. That pen top there is a bit that's just the same as the SARS coronavirus 2. Therefore will be antigenic and recognised by the immune system as a SARS coronavirus 2, even although it isn't, it's an adenovirus. But it's genetically modified to express a SARS coronavirus 2 protein. So that's what that is. So there's two attenuated. Attenuated just means weakened. So it's weakened so it won't cause disease. It's already wounded, it's weakened. So it's attenuated recombinant adenovirus vectors. And a vector, of course, is something that carries the antigen or carries the disease. And in this case, the adenoviruses are acting as vectors for the antigen that the immune system will recognise as a coronavirus antigen. Right, I hope that vaguely made sense. So it's carrying the gene for a SARS coronavirus 2 spike protein. So it's not like an RNA virus that's taking the information into our cells to make the spike protein antigen. It's actually providing it in these recombinated, genetically modified adenoviruses to carry this, to express this coronavirus 2 type spike protein. And again, to be fair, this is a well-recognised technology. This isn't new like the RNA vaccines, which is kind of good. The RNA vaccines appear to be working, but it's all a bit new. Approval already granted in Russia. Right, now Richard Horton is the editor of The Lancet. And some news outlets report he is critical of certain political views. I don't know Dr. Horton. Of course, if you would like to email in or call in or contact me, I would be more than delighted to have him on the channel. But sad that we're even asking questions about the peer-reviewed literature. That's unfortunate. I hope my fears are completely unfounded, and if Dr. Horton can reassure me, I of course will accept his reassurances. Do feel free to contact me, sir. Now, moving on to the next paper. Symptomatic and asymptomatic viral shedding. I'm a bit zoomed in today, am I? Let's go out a bit. There we go, fit in now. Symptomatic and asymptomatic viral shedding in children infected with severe acute respiratory syndrome coronavirus 2. South Korean data. Now, the reason I wanted to include this study is we talked about how important things are in children, but also this is very consistent with other studies from the United States. And it's always good to have this collaboration. So 22% of children were asymptomatic for the whole time, roughly what we've seen in other studies, but 20% became asymptomatic later on, so that means that for a while 42% are asymptomatic. 58% were symptomatic, often, thankfully, very mildly symptomatic. But the length of time children remained symptomatic for was 3 days to 3 weeks. And the paper thought they were probably contagious for longer periods of time. Now, why is the paper talking in such uncertain terms? Well, firstly, I'm glad to see that they know they're uncertain about it, but the reason they're uncertain about it is some children were still testing positive 3 weeks later using the PCR antigen test. They were still testing positive. But the problem is we know that people can still test positive because they're still excreting viral residues, even after they're better, after their immune system has combated the infection. And from other studies, we know that these viral residues are not infectious. So just from doing the tests, the antigen tests on children, we can't tell whether they're infectious or not. But it's looking like children are infectious for much longer than people had thought, and it's not ludicrous to say that some children are infectious for up to 3 weeks, while some children might only be infectious for 3 days. So again, the import of that with the world going back to school can't be overstated really. To me, it means that children are going to spread the virus prolifically. And this is going to result in renewed exponential increase in cases potentially around the world. The problem is we've still got this winter to survive before we have a vaccine. It is this winter that I am worried about, that we could see a lot of cases. We've been reassured by apparently lower infection fatality rates, but they're still not negligible by any means. So my concern is for this winter, and we do see increasing cases in quite a few countries now. Europe, for example, great increases in cases. India, we're going to hopefully look at that tomorrow, great exponential rise in cases in India and all the problems that go with that. Now, third paper. Where are we? Here, no, there we are. Right. SARS coronavirus 2 viral load predicts mortality. So basically this paper is saying that the higher people's viral load when they're admitted, the more likely they are to die. So viral load at diagnosis, independent predictor of mortality. So people were diagnosed with COVID-19, higher viral loads, they're more likely to die. Lower viral loads, less likely to die in hospitalised patients. So it's a large hospital prospective cohort. It's good that it's prospective, the data tends to be better. It's a cohort which is a group, and it was this was the final number after it excluded a lot of unsuitable patients. So they still had well over 1,000 cases. Now this study was clever because they adjusted for all the variables that we know make a difference. So we know that more old people get more sick than young people. We know that more men get sick than women up to the age of about 80. We know that asthmatics are increased risk. We know that atrial fibrillation, the fluttering of the top chambers of the heart, is an increased risk. We know that furring up of the arteries is an increased risk. We know that chronic kidney disease is an increased risk. We know that chronic obstructive pulmonary disease, COPD, is an increased risk. We know diabetes, we know heart disease, we know high blood pressure, we know stroke, and we know that people with some races are at greater risk than others. For example, the American Indians and Alaskan natives have much higher mortality than white people in the United States, and people of African American heritage and Hispanics also have much higher mortality than white people of European extraction in the United States. So correcting for all these, now that is one heck of a piece of statistics. I wouldn't know how to do that, but they've done that, so that's quite clever. And they still find a significant independent association. Significant means they're at least 95% sure it's not a random finding. Independent association, so taking all those out, there's still an independent association. Just the viral load, between viral load and mortality. So if that is increasing death up there, and that is increasing viral load on admission, as one variable increases, the other variable also increases. It's a positive correlation. And the reason I wanted to put this in was that the studies that we've looked at over the past few days, I'm not going to review them all now because we'll be here forever, but if you look at the videos I made over the past few days, we give very strong evidence that the higher the inoculating dose of virus, the more virus someone's infected with, the more likely they are to get severe disease. We know this is true with influenza, for example. There's a lot of circumstantial evidence that it's true with COVID-19. We don't know for sure because we haven't actually infected people with it and worked out how different infecting doses cause different degrees of morbidity and mortality. It wouldn't be an ethical thing to do. But the evidence for it is strong, and that means that anything you can do to protect yourself, like wearing a mask to reduce any viral load, while it might not stop you getting infected, it will mean you get infected with a lower viral load. Therefore, you're much more likely to be asymptomatic. And that simple piece of knowledge could save millions of lives around the world. That's why I wanted to focus on this one. But also what it means is hospital testing needs to change from qualitative, just saying whether the virus is there or not, to quantitative, saying how much of the virus is there. Then we could risk stratify patients accordingly. At the moment this isn't done. We need to move on to a more quantitative analysis. So not just saying the virus is there or the virus is not there, but saying the virus is there in particular infecting numbers. That would be remarkably useful information. Now the final one is association between administration of systemic corticosteroids. Now systemic means we give them via injection or via mouth, so they go all over the place. The converse of that would be local. Like if you use a steroid cream on your arm, that would be local, but this is systemic administration. And mortality, and now this is not for everyone. Don't want people taking this at home. This is only to be prescribed by specialist doctors, critically ill patients with COVID-19. So this is not for home treatment. This is critically ill patients. Steroids must be very carefully prescribed by experienced doctors. No one else should be prescribing steroids, or other people that are qualified to prescribe. Now systemic corticosteroids and versus 28-day mortality. So in other words, they're giving people steroids at 28 days. Who's left alive? Who's died? Simple as that. So it's prospective meta-analysis. Now meta-analysis is good because you can get lots of patients, combines data from different studies, and they had found 7 randomised trials from 12 countries from February to July. So it's a good sample size. And they had 1,703 patients. And of those patients, remember these were critically ill patients coming into hospital, 647 unfortunately no longer with us. Now these patients were randomised, which is good. So some received dexamethasone, which we know works. Some received hydrocortisone. You can see these end in zone, the steroids. So the dexamethasone and the hydrocortisone are very similar molecules. They're both related to these cortisol type molecules that are produced by the adrenal medulla. And the third one they tried was methylprednisolone. Again, been using it for years, very common steroid. Used to use that quite a lot for neurological conditions. So again, cheap drugs, readily available, dirt cheap, off license, been using them for decades, know lots about them, and let's see if they work. Of course we know they do already, but this gives us a bit more information. Well actually no, to be fair, we knew the dexamethasone worked from the Oxford trial, from the UK Centre for Evidence-Based Medicine. So we knew the dexamethasone worked, but what about the other ones? Was the dexamethasone we knew worked, wasn't it? Yeah, dexamethasone. Yeah. Now, corticosteroid group, 768 patients with 22 deaths, so 29% of those died. Control group who did not get steroids, 41% of those died. I mean, there it is. That is just completely convincing. And with these numbers, that is highly significant data. So for the poorliest people, the steroids are reducing the inflammation, reducing the amount of fluid that's collecting in the alveoli, reducing the severity of the acute respiratory distress syndrome, and people are living more. So the steroid group, 29% mortality, the non-steroid group, 41% mortality. And of course this would also mean it would be unethical to carry on this trial now, because we know it works. So this is now known to work. Great reduction in fatality. Absolute mortality risk with higher doses. Now with higher doses, people with higher doses, Now, with higher doses, 32% died in the steroid group, and 40% died with usual care or placebo. So if we give high dose of steroids, we get 32% of people dying. If we give no steroids, we get 40% of people dying. But then when we lower the dose, we get 29% of people dying, and we get 40% of people without steroids dying. So we can see that the lower doses of steroids are associated with a much greater recovery rate. Now, this did not surprise me at all, because a low dose of steroid is going to reduce the inflammatory response, reduce the amount of fluid, the inflammatory fluid that's collecting in the alveoli. Just like when you sprain your ankle. You know, when you sprain your ankle and it swells up, that swelling is the inflammatory fluid. Heat, pain, redness, swelling are the clinical features of inflammation. So I wasn't remotely surprised by this. And we know that steroids will reduce that swelling because they're anti-inflammatory. But give too much steroid, and we also know that steroid interferes with the immune response. So when you give larger doses of steroids, it's going to interfere with immunity, which of course we don't want. We want the immune system to be able to eradicate the virus. So this lower dose of steroid is giving just enough to reduce the inflammation to prevent people drowning in the acute respiratory distress syndrome, but not enough steroid to block or adversely affect the immune response. Now, to be fair, it will affect it a little bit, but this is kind of the trade-off. It's always a trade-off. So these lower dose of steroids, the evidence is now there and consistent with other trials as well. So this is good. This is good to know. And it's simple, it's cheap, it's readily available. You know, there's no reason why every critical patient in the world can't get corticosteroids. These cost pennies, the cents, they're nothing. They're very, very cheap generic drugs. Even the injected forms are quite cheap. Now, differences between the steroids: dexamethasone, 30% survival. Hydrocortisone, 32% survival. So slightly better survival with dexamethasone. Now that says dexamethasone, but that should say methylprednisolone. My mistake. So the methylprednisolone, that's the one we looked at there. The methylprednisolone, is that better than the dexamethasone? Well, there wasn't enough data to judge on that. So we don't know about the methylprednisolone. Is still a bit of a mystery, so we don't know too much about that. But what we do know, or we can't be definitive about that, what we do know is that steroids help, and with dexamethasone only 30% died, 29 to 30% actually. With hydrocortisone it was slightly more, 32%. So it looks like low dose dexamethasone is the one from that data, and we know that's a simple, cheap treatment that we've been using for absolutely years. Wow. Right, if you're still with all that, well done. Just going to finish with a letter. Now, I've been doing a survey in the shops where I live. I live in Carlisle in the north of England. So every time I go in a shop, I say to the shopkeeper, what percentage of people are wearing masks? Because it really annoys me when I see people not wearing masks. So I've talked to a few shopkeepers, and I always ask them. It's not a scientific survey, of course not, but it's interesting to see, and it seems to be about 95%. So where I am, terrible that 5% still aren't wearing masks in shops. But that 95% will make a real difference to the transmission of this disease. So I'm somewhat encouraged, but 5%, you've just got to carry your mask in your pocket all the time, just in case. And you've got to have several, so after the day you put it in the wash, and then you've got another one. It's just like your shirts or your vests or whatever. You just need, you put one in the wash and get another one out. That's what we need to be like with masks. It needs to be part of the daily routine. So still 5% in my area not using masks. A lot better than how it has been. And the other thing that I just don't get, I've been talking to people about reopening meetings and reopening shops and reopening businesses, and they talk about placing hand sanitizers and they talk about plastic screens. And they talk about masks and physical distancing, and all these things are great. It's exactly what we need to do. But then they shut the doors and the windows. You know, the main thing is to dilute the viral load with good ventilation. And if that means the room's a little bit colder, then wear a thermal vest. You know, we are still, as a world, not getting the ventilation thing right. We are so used to coming in and closing the door. Well, don't close the door, jam it open. Get a through breeze, open some windows on the other side. You know, lack of ventilation, to me, is the big thing that we are missing out on. We need well-ventilated public areas. And most of the public areas I've been are not well ventilated. So simple. Spread the word. Ventilate. Someone make up a poem for me. Ventilate to something elate or something like that. So, you know, something like that. You know, we need good ventilation. Right. So Zoe writes, I ventured into town on Friday night in Exeter, hoping to find an outdoor seating arrangement for a drink and food. Fair enough. Outdoor would be good. None was available. So it's still not cold in England, but no outdoor drinking or dining was available in the whole city of Exeter, it would appear. If you're a food outlet in Exeter and you know otherwise, do let me know. All the restaurants were packed. First time I have been in town on a night since lockdown. The seating arrangements were exactly the same as pre-COVID. I was totally confused, totally and quite angry. Calmly, I did ask a restaurant staff member who explained the tables only needed to be 1 metre apart, which means 2 people can sit back to back within 1 metre, therefore is no difference than pre-COVID. Exasperation isn't the word for it. I thought you might like to highlight this stupidity because people were talking loudly. That's a big risk factor, you know, talking loudly. In crowded areas, especially if there's music, you can't hear yourself talk, so you end up yelling at someone who's 2 inches away from you. It's guaranteed transmission of the virus if it's there. In addition, of course, because of the packed seating, so talking loudly inside, poor ventilation, the virus is going to spread. So please, she's written to her MP. Please could you do a shout out to my mum and dad? Okay, we will. John and Leslie Humble, you've been watching for a long time. You are welcome, Mrs. and Mr. Humble. I am delighted you are watching. Please continue to do so. And actually, the reason I've decided to mention this is you've been shielding for a long time now, and a lot of people have been shielding for a long time. So you just remember the people around about you that have been long-term shielding, and you know, make them feel involved in the community by talking to them through the window or taking them around some hot food or anything that involves them. Without the risk of contamination, because there's a lot of people are having a difficult time still in this pandemic. So just look around you and think who they might be and reach out to them. Thank you for watching this video as always.